Good evening, and welcome to this 6 Months Smiles Aligners webinar. Today, our topic is which one to choose, aligners or braces. In this webinar, we will cover how aligners and braces work to move teeth, look at the clinical conditions for which aligners may be superior to braces, and vice versa. We will show how to ensure you achieve a predictable outcome to avoid unrealistic movements, elements that will influence patient compliance. Upon completion of this webinar, the student will be able to learn basic mechanics on orthodontic movement, understand aligners and braces, clinical approach to different malocclusions, the scope of treatment, influence of the appliance on predictability and patient compliance. Let me first introduce myself. My name is Dr. George Perez. I'm a clinical instructor for 6 Months Smiles, mainly in charge of the clear aligner segment. As you can see on the screen, there's a few numbers there that explain my experience that I have with clear aligner therapy. All of this is mainly to reassure you that I have plenty of experience to share with you and have been pioneering all of these systems for a very long time. Okay, let's get right into it. People who are considering orthodontic treatment usually come prepared with great questions when they consult you as a dentist. More commonly, the question at the top of the list is often which type of appliance to use to correct their orthodontic problem. Braces or aligners? Currently, we have plenty of information in the media and online that might drive patient selection accordingly. How do they decide this? How do they make this decision? Well, first, keep in mind that there is not a single right way or best appliance for orthodontic treatment to be done. We know that an accurate diagnosis is the starting place, and that's something that orthodontists are especially well trained at, as you know. After obtaining orthodontic records, like x-rays, photos, and models, the orthodontist will pinpoint the problem and then craft a customized correction. One appliance is not inherently better than another. What is used for an individual correction will be based on the goals of treatment and the patient's lifestyle needs. Some things, however, apply to all patients, regardless of the type of appliance. Let's talk about braces. We are all familiar with braces. Most orthodontic problems can be successfully treated with using braces, as you know. Braces have been the traditional form of treatment used by orthodontists for decades. But today's streamlined braces come in a variety of models: stainless steel, tooth-colored, ceramic, and even gold-colored. More importantly, braces have joined the digital world, and its placement can be guided by digitally created models to help the accuracy when bonding to teeth. This is really a great advantage that we have now with fixed appliances. What about the visibility? Well, there are more inconspicuous options like tooth-colored brackets, braces that go behind the teeth. Other elements will remain visible: rubber bands, wires, or gold-colored brackets. You can, however, choose the colors of your rubber bands, which is great. Removability. For a stable and functional result, braces will remain affixed to the teeth throughout the course of treatment. This is great to deal with patient compliance, for example. On the bright side, you cannot lose them like you would with clear aligners, unless you eat very hard or sticky food, obviously. What about the comfort? There might be some initial discomfort, like with any orthodontic appliance, or when braces are placed or adjusted and brackets and wires temporarily irritate the mouth, the tissues in the mouth. Overall, the discomfort is short-lived and easily managed. Patients become really accustomed to the braces. And what about the hygiene? This is one of the big challenges that for patients to keep the teeth clean. Gums and braces free of plaque and food debris, so bacteria can attack the tooth enamel, causing inflammation. What about the diet with brackets? Those with braces must steer clear of foods that are hard, sticky, crunchy, chewy, to avoid breaking a bracket or popping a wire out of the bracket. Patients should opt for water instead of carbonated drinks, flavored waters, or sport drinks. These can contain acid and sugars, and both are bad for tooth enamel. Let's talk a little bit about clear aligners. I think we are very familiar with the advantages that clear aligners offer. They're very available in the market and they're constantly in front of us wherever we go. So they are plastic replicas of your teeth, basically, like a mouth guard. Wearing them puts a gentle pressure on the teeth, ever so slightly, gradually repositioning them. Aligners are one of the many technological advancements that have made orthodontic treatment less conspicuous and more controlled and predictable. The visibility, well, aligners are clear, thin, and plastic-like trays, making them virtually invisible. Tooth color attachments are frequently placed on the teeth to help guide the teeth into place. We'll talk about attachments later on. Aligners are designed to minimize the appearance of the appliance to better fit any lifestyle. It's very easy to wear these appliances because they're very aesthetically pleasing. They're removable, and many patients appreciate that aligners are removable because they can take them out to eat, to brush and floss, or for short periods of work or social occasions, which is also a disadvantage when you want them to be quite compliant. The key responsibility is wearing them as prescribed. That typically means a minimum of 22 hours a day in the correct sequence. Because they are removable, aligners can be easily lost or damaged. They fall out of the pockets or purses and might even get wrapped in a napkin and thrown away. They're very comfortable. While there might be some initial discomfort when a patient switches to a new set of aligners, the discomfort can be easily managed. Removing aligners because they're uncomfortable defeats the purpose, and you have to be very careful and tell the patients this. Aligners cannot work unless they're in the mouth. One of the best advantages also is the hygiene. It is critical to avoid drinking soft drinks, though. Flavored waters or sports drinks, just like with any orthodontic appliance, you have to be careful because that might cause some decalcification. Liquids seep into the aligners, and if they contain acid or sugar, they can rapidly lead to staining of the teeth and extensive decay. So we need to be careful with that. Teeth need to be spotless when aligners are placed in the mouth. So always tell the patients to clean their teeth before they put the aligners on. Otherwise, they are food and debris traps. The type of appliance that we use for orthodontic treatment is actually far less important than the skill in the hands of the person who is providing the treatment. We need to seek programs that will improve our skills, the education, experience, and expertise to evaluate diagnostic findings and translate those into a treatment plan that will help provide a beautiful and, more importantly, a functionally smile. As you can see on our image, we have a patient wearing both appliances, and that requires obviously a degree of skill that we will be we'll talk in depth later in the webinar. Let's talk about how we actually move teeth. How do we achieve these predictable teeth movements when moving teeth with our aligners? Well, we can only achieve this control by controlling the forces or the delivery of the forces that will move the teeth. And how do we do this? Well, let's understand what we're working with first of all. Whenever we try to apply, or whenever we apply a force onto the surface of a tooth, we're working with a tooth organ that has and contains, obviously, within the socket, periodontal ligament. When you apply a tipping force, there will be areas of pressure, or areas of compression, and areas of tension around a center of resistance. This, in fact, will provide, or will start releasing an activity of cellular activity that involves osteoblast and osteoclast. So whenever you apply a force on a tooth, whenever you have an area of compression, will release osteoclast, creating the space where the teeth needs to move to, and osteoblast, that it's building the bone that you left behind. That is within the tooth organ. What about the plastic and the material that we use as a clear aligner? Well, you have to take into account that for every action, there's an equal and opposite reaction. And providing forces on an aligner will result in other unwanted movements. So you need to compensate, or you need to take that into account when treating cases with clear aligners. If you work with a decent company, of course, they will ensure that these movements and these reactions on a plastic will be overcome. When you provide different forces, different movements, for different movements like rotation, intrusion, and extrusion, you need to understand the actions and reactions that the plastic will have and ensure that whatever you do with the planning, it's related to these forces. We need to understand the material that we work with. It's not the same to work with a plastic or a type of Essex aligner, for example, and to work with a material that, like the one that we use for aligners in 6-month smiles, which is Cendura Flex. This dual shell material will provide superior force in retention. The active fibers will remain, will provide the forces for longer periods of time and improve the elasticity. Think about the night-tie wire when you're doing fixed appliance. It's exactly the same. It will have a shape, a memory shape that will always ensure the movements are predictable and more constant. It's highly stain resistant, and it has great patient comfort because of the dual shells that we provide. As you can see on the animation, we have two elements on the aligner. We have an outer and an inner shell and a more rigid in the middle. So it's the elasticity or the aligner flexes upon insertion and returns to original shape over time. This is very advantageous because we provide the rigidity necessary to move the teeth into position whilst we ensure it's comfortable when inserting. So you don't have that clicking force that you normally experience with other more rigid materials. All of these elements will ensure that we achieve the orthodontic paradigm, which means gentle and continuous forces for better orthodontic movements without resorption. Of course, we need to consider that the rate of movement depends on many factors, such as age, growth, periodontal condition, and any medications that the patient is taking. Let's look at the movement with brackets and wires. We're all familiar with the fixed appliances. We know that the brackets will ensure that we can engage a wire that will follow through as you change it over the movement and will medicate the teeth to follow this movement. So basically what we're trying to say is that we're changing the shape of the teeth by means of the brackets so we can insert a wire that will force the teeth to follow the shape of the wire because the wire will bend onto the crowded areas of the teeth as we see on the image. But with the memory that we have implemented in the wire, will ensure that the teeth move into the correct direction gradually and achieve an aligned position. So observe that foundation of movement, and if we compare it to the clear aligners, it's in a similar way. If you imagine or compare the aligners being your wire, as you can see around the teeth, in this case, the aligner will encapsulate the teeth and will control the movements, or will provide individual control movements until you achieve the alignment in similar ways. We also need to change the shape of the teeth, and that's why we provide attachments. Attachments, so people understand what they're for. Basically, they will aid, increase the predictability of certain movements that may not be able to be achieved without them. So we basically change the shape of the teeth for the aligner to engage in a more accurately way and achieve certain movements. For example, incisor extrusions will not be able to be achieved without an attachment because of the shape of the incisor is such that when the aligner tries to extrude the tooth, it will just slip off. So it's always good to have this type of aid in order to achieve that. So if you compare with the brackets, your aligner will be, as you can see in green, like the wire, it will be the equivalent of your night-tie wire, and your brackets will be the equivalent of the attachments. So both will work as a little unit to achieve this and deliver this final position. That's basically a very, very simplistic way how the aligners and how the brackets work to achieve the specific movement. As explained before, the key to success for any orthodontic treatment is to understand that we're dealing with what we're dealing with by means of a diagnosis. Diagnosis is not something that is appliance specific. An orthodontic case should be treated first and foremost according to the basic principles and not to suit the appliance that the doctor or patient desire to use. Certainly, patient and doctor preferences must be taken into account, but only after a thorough examination and diagnosis are made. In that way, the appliance limitations can be exposed and the patient can make a decision based upon properly informed consent. How are we going to achieve this diagnosis? Well, we have designed a systematic approach to this diagnosis. There are many elements to consider when diagnosing a case. Obviously, we're going to analyze the arch length, and within the arch length, we're going to find crowding issues or spacing issues. On the vertical dimension, we will find deep bites or open bites. On the transverse dimension, we will find cross bites or midline shifts. What about the sagittal dimension? We may have to maintain it, change it, or we'll see increased overjets. Let's talk about the arch length discrepancies. We will find in the crowding that non-extraction, expansion, proclination, and IPR will be your main space achievers. Whenever you have any cases with crowding, the objective is obviously to unravel this crowding, find a solution for the alignment. And the most common elements to achieve this unravel this crowding are the space achievers. Expansion, proclination, or an IPR are the most common ones. Then we have distalization, and of course, extraction will just deliver immediate availability of a space. We need to assess, obviously, if this is a requirement in every case that we work with. What about spacing? Well, spacing, you will normally use it or normally close it by retraction of the teeth. We need to be careful and assess correctly if there is a tooth size discrepancy, considering the Bolton's analysis. If that's the case, if your arch is far too long or far too big to fit all of the teeth, and closing the spaces by retraction will mean that you collapse your arch, then obviously you have to consider redistribution the spaces for restorations, because what it means is that your teeth are far too small to fit within the arch. What about proclination? When are we going to do proclination? We need to consider the patient's profile. We need to consider whether these teeth are proclined or are palatally inclined. What about if we want to increase the arch length? Do we need to increase the arch length? Can we afford to have the teeth proclined? Will this affect the patient's profile? All of these are indications, all of these are considerations that we need to assess when deciding if proclination is needed. Obviously, that will be a very good space achiever and will create space to resolve the crowding. Whenever you have attachment loss or recession, we don't really want to approach a case with proclination. Obviously, existing proclination will be against, needless to say, will be against the proclination indication. Moving on the space achievers, what about IPR? Well, in the indications for IPR is to maintain the arch length, remove the black triangles, create a space to resolve crowding, and deal with tooth size discrepancy. When I mean to deal with tooth size discrepancy is when you have an arch with tooth size discrepancy, for example, the upper arch, and you're required to retract the upper incisors to close the spaces, and you need to provide IPR, of course, for the lower incisors to avoid any collisions. What about the contraindications for IPR? Well, you really want to stay away from any thin enamel or any issues with enamel, like amelogenesis imperfecta. Poor oral hygiene is obviously a no-no, but at the same time, I will never start orthodontic treatment if there is poor oral hygiene. And you need to check if the patient hasn't had already IPR due to prior ortho treatment. Moving on the systematic approach to diagnosis, let's look at the transverse and vertical plane. What are we going to find on that? Transverse plane, we will find crossbites that might be favorable or less favorable. On that particular sense, you want to assess if correcting the crossbite will mean that you will achieve a stable and functional occlusion and not something that will end up, for example, on a cost-to-cost relationship. Normally we try to address this for anterior segment only. Let's look at the appliance comparison. When we have certain elements of malocclusion, we look at how the braces and aligners deal with these malocclusions. Crowded and overlapped teeth. With braces, we know that more effectively can correct severe crowded, whereas aligners, mild to moderate. This we need to remember that is related to an appliance, when talking about aligners, that is limited to 20 aligners, which is what we work with. It doesn't mean that severe or crowding cases cannot be treated with aligners because it's an inferior appliance. It's just that we are limited to 20 aligners with Siegmund Smiles aligners. As you can see, there's a huge overlap clinically between the two appliances. There are certain elements that will work a little bit better with aligners, a little bit better with braces. But in fact, you can see already that these conditions, these clinical conditions can be overlapped in a very good way with both appliances. Case-specific clinical conditions may drive the selection of the appliance. So let's look at more specifically at the appliance comparison. So we have braces on one side and aligners. For braces, we have, of course, the fixed control that provides a fixed appliance, faster root movement, cheaper lab fee for dentists, and no compliance issues because it's fixed. Faster root movements because we have a completely fixed bracket controlling this root movement, which is something that is quite challenging to achieve with aligners for the same reason. What are the advantages of aligners? Well, we have individual tooth control. That means that in one arch, we can decide whether to move a segment of teeth in different directions, for example, extrusion, rotation, root movement, all at the same time. And for example, another segment of that arch to remain immobile without any forces. This is good when you have cases, especially with adult orthodontics, very common with adult orthodontics, cases where you have arches with bridges, implants, anything that you may want to leave well alone and not prescribe any movement. So this is a great advantage. It's predictive and directed outcome because everything that you program or any plan that is programmed on the digital plan will be 100% replicated into the aligners. And that will result in a predictive and directed outcome. It's related to what I mentioned on the individual tooth control. Minimal chair time. Well, needless to say, when you, other than doing a bit of IPR and bonding some attachments, there's not a lot more that you have to do when treating patients with clear aligners. The clear aligners do the work for you, basically. Easy oral hygiene. Well, the fact that they are removable brings advantages and disadvantages, but certainly easy oral hygiene and aesthetically pleasing is one of the main advantages of having this removable and clear appliance. Let's look at the disadvantages when treating patients with clear aligners. Compliance is, as you know, 100% under the patient's control. And as much as we want to believe that they wear the aligners all of the time, it's very difficult to ensure that this is the case. So many of the issues that you will have with teeth not following through the prescribed treatment are related to the patient compliance. Something that, of course, you wouldn't have with braces, would you? Difficult root movements can take longer for the same reasons that I mentioned earlier. An appliance that is not fixed to the teeth and the reactions that you get of separation with the plastic will provide less predictability of difficult root movements, making it slower to an extent, and also needed to pay more attention on this type of movements. Any root movement, anything that you try, whenever you try to move an apex or the root through the bone, it's always going to be one of the most challenging orthodontic movements with any appliance. Of course, there's a need of attachments, but then again, with any orthodontic appliance, you need to change the shape of the teeth somehow to redirect the forces and achieve predictable outcomes. So although it's a disadvantage because a lot of patients don't like it, right? They come to you for an aesthetic appliance, and when they see the attachments, it's not very well taken by them. But it's something that after explaining the situation and after explaining the nature of the attachments, patients seem to accept it and go through the treatment. There are certain clinical elements that are very common when we deal with patients, and they can easily be treated with clear aligners. Periodontally compromised patients are always a green light for clear aligners, for the reason that I mentioned earlier. Individual tooth control, deciding the rate of movement that we're going to implement on each particular tooth or a segment of teeth works really well with periodontally compromised patients. And when I say periodontally compromised patients, I'm talking about patients that had previously periodontal disease, non-active periodontal disease right now. So perhaps we want to be a little bit more gentle with those teeth. Enamel compromised patients, well, there are elements or there are instances where we can provide orthodontic treatment to patients that have enamel compromised enamel, and without the need of attachments, IPR, or anything like that. So they can be treated with aligners really, really well. Deep overbites, it's very, very useful when you have clear aligner treatments because the pure nature of the appliance, which is a certain thickness of an aligner, will immediately disocclude the arches. So whenever you want to correct overbites or deep bites, you will find this a good aid when treating these cases. Mild to favorable anterior open bites, you have the opportunity to do this, especially when treating anterior open bites that are related to anterior proclination. Not so much the ones that you have to intrude posterior segments, because obviously that will take a lot longer. But if you look at anterior open bites that have been created by dentally related issues rather than skeletal issues, it will be easily corrected. Anterior cross bites, refer back to what I mentioned about the thickness of the aligner. You will disocclude the arch immediately just by wearing the aligner, just by the nature of the aligner. And that will help correct an anterior crossbite very, very easily, and some favorable premolar crossbites as well. Almost all spacing cases and lower incisor cases. Well, the individual root control that you have will allow you to provide a good anchorage and bodily movement to correct or to close up lower incisor extraction cases. Missing teeth and implant cases also works very well, especially with missing teeth. I would like to mention that we can provide Pontics. So as the patient wear the aligners, we can fill that gap by means of a virtual Pontic that you can fill with a Pontic material. So imagine that you paint that space on the aligner and provides a temporary fill for that extraction place or missing teeth area. Implant cases, very well managed with aligners because of the individual control movement that I mentioned. We can decide which teeth we don't want to move, and you don't have to bond anything to them. Let's look at some of the parameters for aligner patient selection. Whenever you treat a patient with aligners or with any orthodontic appliance, the root development must be complete. At least that means that you're not going to create any issues when moving the teeth orthodontically. Crowding should be between 7 to 10 millimeters. Mild rotations are more predictable. Just consider 20 to 30 degrees. Again, it's not that you cannot do more with clear aligners. We are being very specific about the time frame that you have. And with 20 aligners, you definitely will correct this very, very predictably. And we're talking about incisors, canines, and premolars, even molars, okay? We will look at the parameters of predictability in a second. Good periodontal health and restoratively healthy. You need to ensure that all the restorations and any work that is required needs to be done before any orthodontic treatment. You don't want to flare anything whilst you're doing the orthodontic treatment because it might affect your predictability of movement. And not only that, you might have to stop the orthodontic treatment halfway and do the restorative work, and then you might have to submit new impressions and so on. So it's just not a good workflow. It's better to do everything from the beginning. This point is very important. Patients need to understand the compliance requirements. It doesn't matter how good your appliance is, how good your planning is. If the patient doesn't wear the aligner, nothing is going to work. So make sure that the patient understands the compliance requirements from the beginning. Occlusal consideration, opposing arch and guidance. You need to ensure that you understand whether the posterior segment is in a position that you're going to be able to provide a good treatment without causing any further problems. What about the case selection or patient selection for braces? Well, the most common complaints with braces is the crowding, spacing, protruding teeth, uneven heights of teeth, and asymmetrical smile. It's very, very well managed with braces as well as with aligners. But the least common complaints, posterior crossbites, minor overjet, bite problems, bite dysfunctions, and midline deviations. Especially midline deviations are a complaint or an issue that needs to be well assessed and well diagnosed. If it's related to something that you can easily correct within 6 to 10 months, it's fine. But if it's something more related to an skeletal discrepancy, of course, you won't be able to deliver that solution. Everything takes us back to diagnosis. You need to diagnose every single case perfectly before you move on to any treatment. Let's look at the 3 main clinical differences of 6-month smiles, fixed appliance between comprehensive ortho. With 6-month smiles, fixed appliance, you won't be able to change the angle class. And at least we're referring to jumping from a full unit class 2, for example, to a full unit class 1. You will definitely require a lot more than 6 to 10 months treatment for this approach, but I'm sure you already know that. There'll be little change to buccolingual root positions, and we're not aiming to correct significant midline deviations. It's related to what I mentioned earlier. It's all down to diagnosis. The indirect bonding trays that we have, including your patient tray kit, when you access this provision of treatment, this will reduce the stress of placing brackets. So one of the main challenges when providing orthodontic treatment with a fixed appliance is placing the braces correctly, placing the brackets correctly. With the technology that we have of indirect bonding trays, you don't have that stress. It will come perfectly prescribed for you and makes the braces on appointment mostly diligible. So it's very, very easy to place. What about the patient selection with braces? Well, most adults with crowded teeth are candidates, more or less 80%. If patients have increased overjet, you need to pay special attention. And this is related to the anteroposterior relationship. If your increased overjet is related to a class 2 relationship, and suddenly you're going to worsen it from going to a class 2 div 2 to a class 2 div 1, you need to pay special attention to that and consider if that is a correct approach and if the patient is going to be able to take this increase on the overjet. It is important to understand where the teeth will move as the wires work. Other important factors to consider when giving an orthodontic consultation is aesthetics versus function, length of the time in treatment. Patients might want a solution that is very, very quick, so you need to consider these factors. Upper versus lower treatment. Some patients only want the single arch treatment, so you need to consider these factors. A straightening, closer spaces, midline corrections. Patients might address this specifically. Financial constraints are sometimes a very common aspect that will decide or will guide you to the decision of whether to have fixed appliance or clear aligners. Consider the overall restorative objectives. If there's any veneers, crowns, bridges, or anything that has to be done, you need to have a good communication with whoever is doing these restorations, or if it's yourself, make sure you plan it in your workflow of orthodontic treatment, and you basically want to ensure you leave your arches in the correct position to then take your veneers or your bridges or implants or whatever you're planning to do. What about the aligner limitations? Let's look at numbers. So whenever you have crowding, normally the aligners will be able to correct 7 to 10 millimeters of crowding. Again, this is related to a product of 20 aligners. It's not saying that you cannot do more with more aligners, but we are looking at 6-month mouse aligners and we need to ensure that we understand the parameters correctly. Rotations, 20 to 30 degrees are more predictable, as we mentioned before. Intrusion and extrusion on the posterior segment, on the anterior segment, 2 to 2.5 millimeters. Posteriorly, 0.5 millimeters. Proclination and retroclination to correct your very proclined teeth, 15 to 20 degrees. Mesiodistal root torque, 15 degrees. Things that we will red flag is open and deep bites. Of course, it really depends on the nature of this open and deep bite. As mentioned earlier, if it's something related to skeletal discrepancies, it will be more difficult. But they are very easy to correct anterior open bites or deep bites, especially when they're related to proclined or retroclined teeth. Because when you manage to solve this issue, the proclination or the retroclination, you will achieve what we call relative intrusion or relative extrusion. Posterior crossbites are more difficult, especially when you have a time limit. The main issue with posterior crossbites is the fact that when you have a patient that has been biting with a posterior crossbite for, 30, 40 years, and then suddenly you correct that, you're rebooting the whole posterior segment or the whole posterior occlusion, and that requires a lot of adjusting to ensure that you don't leave a patient with a traumatic occlusion. So we don't tend to correct the posterior crossbites. Significant anteroposterior movements, well, again, is related to our limitation of time. So I wouldn't recommend to jump or try to jump from a class 2 full unit class 2 to a class 1 because you will end up short. Let's be more specific with the parameters of a predictability with aligners. So for incisors and canines, you want to do 35 to 40 degrees for proclination and retroclination. Excuse me. Mesiodistal root torque, incisors and canines will be able to do 15 to 20 degrees. Anterior rotations for incisors up to 40 degrees. Anything that is a little bit rounder like canines and premolars, 30 to 35 degrees will be more predictable. Anterior extrusion, incisors and canines, up to 2 millimeters, which is pretty good. And remember, we will need to use use the help of aids like attachments to achieve that predictably. So not just by wearing the aligners you will achieve extrusion. You will need extrusion attachments for that. Premolar extrusion around 1 millimeter. Anterior intrusion, this is really good, up to 2 millimeters. It's very helpful when you try to level Kerves P or correct deep bites. Premolar intrusion and molar intrusion up to 0.5 of a millimeter. This is a little bit more challenging, mainly because you start running out of leverage and anchorage at the back of the arch. Incisors, you can do more because of the anatomy of the roots and because you have either side a good amount of anchorage provided by the premolar segment and the molar segment. Incisor palatal lingual root torque for upper and lower incisors, 15 to 20 degrees. What about the unpredictable movement with aligners? Well, we will really not attempt mesiodistal root uprighting with premolars. Due to the shape and anatomy of the roots, there's a lot more bone to go through there, so it will take a lot longer. Posterior extrusion more than 0.5 of a millimeter, or posterior crossbite corrections. What are some factors affecting the predictability? Well, the shape of the clinical crowns. Whenever you have issues with the shape and the size of the crowns, will be a particular problem because the key of success of an aligner is to control the roots via the crowns. So if you have very little coverage of a crown or very little availability of a crown, your predictability will be reduced. Long divergent and divergent roots are challenging, and age and bone density, age of the patient and bone density will always play an important factor on the speed as to which we can achieve the final and predicted outcome. Elements related to the patient compliance affecting the predictability. Well, aligners have to be worn for a minimum of 20 hours a day, and only taking them out when the patient eats or drinks any sugary drinks, and for obviously dental hygiene, for cleaning, brushing your teeth. Each aligner is worn for 2 weeks, and patients might break or lose their aligners, so it's something to consider when going through the ins and outs of the aligner therapy with your patients. Sometimes tracking issues cannot spot it in time, so teeth that are not responding predictably to the movements, if you don't have a good schedule to review your patients, you will find it really hard to monitor these issues. And when you see the patient after, I don't know, 5-6 weeks, might be too late. So that is an issue with aligners. You need to clean the aligners each day to maintain proper oral health. Make sure that the aligners are not full of debris. That will create an issue with your hygiene. What about braces? Well, when you have braces, of course, you have more. You are more restricted on the type of food that you can eat. So hard or crunchy food is not advisable. Brackets might debond. That's why, and patients rejecting treatment for many reasons, aesthetics or perhaps allergic reactions is a common situation. And hygiene can be difficult around brackets because it's a more retentive appliance. And since you cannot remove it, there's a constant undercuts and retentive elements that need to be looked after and cleaned more thoroughly and diligently. This is a typical aligner case. A little bit of crowding on the lower incisors, not so much on the upper anterior segment, and within 3 to 4 months, everything is done. That obviously we're looking at cases from mild to moderate crowding. This one is a little bit more challenging. You can see upper incisors being overlapped and presenting a higher level of crowding, constricted or narrow posterior segments, premolar segments. Very nicely treated with aligners because you can expand the arches, create a nice broad smile, as you can see there. Even retract your incisors, your anterior segment enough to reduce your gummy smile, which is a great achievement with this case in particular. Obviously, the whitening is a fantastic result as well. And moving on to the complexity, as you can observe in this aligner case, you have very constricted premolar segment, giving you a narrow arch. The missing premolars are not obviously ideal, but the good thing, the good thing, if there's any good thing on extracting premolars, is that both upper and lower arches have premolars missing. But you can see that the upper incisors, the upper centrals, present a more crowded disposition, especially with the laterals being more palatally placed. The lower incisors present a high level of curvus P, and after alignment with expansion of the posterior segments, alignment of the anterior segments, you obtain a nice result. This is a common example of when you cannot fully correct a midline shift, and that is because of a discrepancy on the anterior-posterior segment. Correcting that midline will require perhaps more IPR, aggressive IPR, which in fact is not needed and is nothing affecting the function. So it's just an aesthetic element. So there you go, before and after a few aligners. Typical braces case, as you can see the progression from the initial place, from the initial position, all the way to month number 5, when the braces are off. You achieve a nice root control, a nice alignment of the upper and lower anterior segment in virtually no time. A bit more complex when you have the need of extrusional movements on the canines. With a fixed appliance, it's very easy to achieve, or at least more predictably, because you have a fixed appliance that will provide more aggressive forces, more directed, more controlled, because it's fixed to these canines, and achieve a nice progression of the arch. As you can see, the arches have also been expanded, and the overlap on the incisors on the lower arch is achieved. This is the type of cases that we get, and you guys are submitting to us, with deep overbites and moderate, mild to moderate crowding, a little bit more severe on the lower incisors, high curvus P, but we can successfully correct with the clear aligner option and achieve a nice and decent result. This particular case shows a more challenging position on the upper canine. As you can see, very out of the arch. And normally, this is one of the advantages that we get when using an appliance and a system that will provide a virtual setup. Normally, you will see this just by assessing the photos, and you will find yourself thinking, this will never happen. This will be too challenging. But when you start planning this digitally and creating the space, or unraveling the crowding, and putting the protocols of space achievers, of expansion, proclination, and IPR, you'll be very surprised of how much correction you can do on these otherwise very complex cases that you assess with your photos initially. So it's one of the beauties that we have with digital planning and an appliance that is predictable and related to a technology that will provide a treatment that is planned correctly and staged correctly. So we have the availability with 6-Month Smiles to provide mixed therapy, as you have gathered. This is fantastic when your arch, or when one of your arches is out of scope for the provision of clear aligners. Just because you may have very big root movements, very big rotations, and so on. So providing the option and the solution of a mixed therapy is a fantastic approach for any case that you may have in your practice. So I'm pretty sure that after all that information, you're feeling a little bit confused. What am I going to choose, aligners or fixed appliance? You have been telling me about how amazing both are. And the reality is that, yes, both are really, really good. Both appliances work fantastically. And ultimately, the decision, if we go back to the beginning, is related to many, many aspects. But the most important one is you. You are the one that is going to make the decision. You and only you will be the one that will take care of your patient, will do a diagnosis, will do an orthodontic assessment and diagnosis to come with the solutions that will be more accurately, more efficiently provided in your practice. You may want to take the path of fixed appliance and invest your time learning that. Or you might want to give it a go with aligners and find yourself that it works really well with your patients and within your practice, and getting your team involved and getting them all excited. Well, guess what? With 6 Month Smiles, you can get everything under one roof. And this is what we are proud of showing you today. It's not about an appliance. It's about you, and we provide an orthodontic solution for all your cases and anything that you need within your practice. So we provide a guided ortho system that provides you with a practical and turnkey solution for adults with crooked teeth or misaligned teeth. We designed this specifically for you. We designed it to address patients' chief complaints within 6 to 10 months, not to have 3 years of comprehensive ortho. We have specialist orthodontists to do this. So we help you achieve or select your patients accordingly to these realms, to these parameters. The digital treatment plan that we have is done by orthodontists. They're no machines, they're no technicians. They're perfectly skillful orthodontists that will apply these skills and knowledge to provide you with the most predictable outcomes. You're not going to get unpredictable, unrealistic approaches on any of the plans that we provide on our Confidex solutions. And we have a seamless switch from aligners to mixed appliances or clear braces, depending on the patient's needs, as I mentioned before. So as you can see, we offer braces, aligners, and mixed appliances. More aesthetically pleasing, but more effective. Whatever you prefer to invest your time, we help you and we support you with that. More to that point, we offer a free support or a free mentoring with any case that you submit with 6 Month Smiles. We're going to have an online forum and one-to-one support with clinical specialists, and we have vast amount of information on our website, online, and through webinars. As you can see today, you can always go back and find any information that you want related to any orthodontic solution. We provide education. You can watch entire courses when you log into our website, when you become part of the team. And we provide videos, posters, brochures, downloads, and everything that is helping or that will be helping you in your practice to provide and to promote this service. So don't hesitate. Contact us whenever you want, and we'll be helping you with getting started with 6 Month Smiles. Thank you very much for listening to this podcast, to this webinar. I believe we have some questions, so we're going to look at what we have here, and I'll try to answer all of your questions. So, Dr. Trivedi, we received your question. I believe we say, how do you decide whether to extract a lower incisor or premolar, or which one? Well, we go back to the same point. Everything that we do is down to assessment and diagnosis. if I want to extract a lower incisor, it's because I realize that the posterior segment is solid. So why would I extract the premolars? And also, in a very simplistic way, I would say a lower incisor will provide perhaps the enough space to correct what it might be a class 3 relationship. That's why you will do a lower incisor most of the time. But the importance here is not a recipe. It's not, oh, I always do lower incisors, or oh, I always do premolars. It's all case by case, and it's related to your assessment and diagnosis. I have to tell you, we don't really extract premolars with any orthodontic appliance with 6-month smiles, because that is related to a longer treatment, so and a more comprehensive approach. So we don't tend to do that. Okay, I hope that answered your question. Next question. How did you diagnose and decide what to extract in a patient who has a bimaxillary protrusion with a class 1 bite, and all 4 canines, rotation, and right maxillary incisors in crossbite by 1 millimeter, posterior solid crossbite? Okay. Well, this is a tricky one, because for every single aspect that we try to assess, we require photos to, of course, have a look properly at what the patient presents. I don't know if I will go for extraction straight away, because there might be, as I mentioned earlier, you might be surprised that when treating with a digital plan, you will find a lot of ways of creating the space, and perhaps you don't really need to consider extractions. But if there's a need for extractions of premolars, I will probably recommend to refer that case. And as I said, I'm sorry that I cannot answer your question 100% because I don't see the photos. But if you have all the posteriors in a crossbite, I will be considering assessing whether this patient has an skeletal problem. And perhaps you won't be able to treat it or to give a solution for this skeletal issue, okay? I hope that answered your question, but if it hasn't, please feel free to email us the photographs, and we'll be more than happy to give you a more concise and more specific assessment. We have a next question. We say, Dr. Kirk says, why do you say that aligners are better at expansion than fixed appliances? Expansion is easily done with fixed appliances, and in my opinion, it is much easier. No, my suggestion is not that it's easier with aligners. I think both are perfectly achievable with both appliances. Both expansion elements will be able to be achieved. The only difference I will say in terms of expansion, that, by the way, let me just explain this. Expansion, it's a term that we use very loosely with these orthodontic appliances, because what we are really doing is flaring out otherwise constricted premolar segments or posterior segments into a more upright position. Because the real expansion is when you break the bone and allow it to heal with a screw and you know what I mean, so do a proper expansion. So we use that term very loosely. The reality is that when we flare the premolars and the posterior segments, in a way you have a little bit more individual tooth control when doing fixed appliances, aligners, I'm sorry. But no, it's not easier or better to do it with an aligner than a fix. You can achieve both equally successfully. Okay, I'm reading your question, so sorry if I take a couple of seconds. Says, how do you treat patients with posterior crossbites with all 4 maxillary molars having zirconia and ceramic porcelain crowns and mandibular all natural molar teeth? I wouldn't recommend moving orthodontically molars having porcelain crowns or zirconia crowns. The reason for that is trying to move teeth with any orthodontic appliance. As I mentioned at the beginning, we try to move crowns or control crowns to move roots. If your forces are being directed to zirconia or ceramic porcelain crowns, you have to go through the layers of ceramic, metal, and the cement. So I don't know how predictable will be to control those roots through all of those layers. So I will try to stay away from correcting something so challenging as a posterior crossbite when you have this type of crowns. Alternatively, what some people do is remove the crowns, if this is an option, and place something directly bonded to it, so you have direct control, and then provide this treatment. But it's, again, case by case, we need to assess exactly what we're dealing with. Perhaps it could be just a little bit of expansion, and we might give it a go. But if it's a full cusp jump on a molar, I will really stay away. Also because those crowns were made to match the position of the natural teeth. So you might not end up with a very solid occlusion, okay? Okay, let me just read the next one. How much does an average orthodontist charge for treatment of the following case? Posterior crossbite, maxillary molar crowns, porcelain or zirconia, anterior crossbite with tooth number 7, all 4 canines rotation, periodontally good currently, but had juvenile periodontitis, which is well maintained. What treatment is in best interest? Duration of treatment. Right. Okay, this sounds like a very comprehensive assessment. And if I was the orthodontist, I will first of all assess whether this is achievable or not. So we go back to the same point. We need to assess whether this is going to be able to be treated. And the same point with the posterior crossbites with porcelain and zirconia crowns. However, in terms of charges, you'll be better off checking in your area what are the normal rates that your orthodontist or general dentist are charging. So that's what I will suggest to do in terms of charges. We can give you some help when and guidance when treating patients orthodontically in terms of charges, but then will be related to what the complexity of the case is. I can certainly give you some advice. So if you have any cases in particular that you would like us to assess, send us over an email, and then we'll get back to you, okay? I think we have one more here, 2 more, okay. My right side does not occlude completely due to me getting braces, my braces off early when I was a teenager. Will an aligner be able to shift maxillary posteriors maybe 3 millimeters, or will this be better with fixed braces? I am assuming that when you say shift, you're talking about either a transverse movement or a vertical plane. So you can do it either way, with fixed or with clear aligners. But again, we need to understand the etiology. Perhaps your right side does not occlude completely due to premature contacts on the anterior segment. If that is the case, then we need to deal with the anterior segment. We don't need to deal with your posterior segment and allow your mandible to continue the rotation. But again, this is only, unfortunately, this assessment or on a case situation needs to be done with the help of photographs. And again, please send us your photos, and I will be more than happy to give you a more concise assessment on that situation. In terms of whether you can do it with fixed or with aligners, you can certainly try both. But again, we need to understand the etiology of the malocclusion. Okay, well, I think that's all the questions we have. Very interesting questions, and the fact that I did not get many questions related to aligner capabilities and braces, I'm trying to assume that it's very clear. or not at all. So I'm hoping for the first one. Your questions are related to case assessment, and as I mentioned before, I will be more than happy to answer them if you send us over some photos. Okay? Well, thank you very much for attending. I will be looking forward to hear from you if you have any more questions. And for tonight, I think that's all. Thank you.